Good evening to Brian. I'd like to introduce my friend, Dr. Brian Weinshenker. Many of you have probably heard him at the neuroinfectious and neuroimmunology symposia that we organized in 2013 and 2015 from Fine. But after that, I think he's been back in India and we've heard him at the AAN as well. He's currently consultant in the Department of Neurology and a professor of neurology at the College of Medicine at the Mayo Clinic in Rochester. His pioneering contributions have been in fulminant demyelination, NMO. He was part of the team that discovered the NMO IgG antibody. And more interestingly, he's going to tell you about a sign that, well, I'll let him go on with this. And obviously, he's he has seminal contributions all across neurology. So over to you, Brian.
Thank you very much, Roop and Sudhir. It's a pleasure to be with you. I know it's a very difficult time worldwide, and hopefully by joining in this CME, we're returning to somewhat of a normal state of medical education. We're going to leave COVID behind for a while, and it's a pleasure to talk with you about diagnosis of MS. I'll just pull up my slides, and I hope you can all see them.
Yes, we can.
And this is a topic, of course, discussed by many people, and I would say the traditional message that many of my colleagues would give you is that it's very critical to make a very early diagnosis of MS, because MS is a potentially very serious disease, and we have treatments that are effective in reducing disability, and the earlier we can get patients on treatment, the better the outcomes. While I certainly don't want to disagree with every aspect of that last statement or those last few statements, you're going to get a very different message from me tonight. And of course, the truth lies somewhere in between, but let's get into it, and maybe we can have some discussion about the importance of early diagnosis at the end. These are my disclosures. Very few relate to what I'm going to talk to you about today. And I'm going to start with a quotation of one of our, unfortunately, very recently deceased, he died just in the last month, Dr. Jack Graybow from Mayo Clinic. And he always said that the most important thing we can give the patient is an accurate diagnosis. And I think some people would take issue with that. They would say, now, what good is a diagnosis without treatment? But the fact is, in neurology, if we do not have the right diagnosis, the treatments we are going to give patients are going to be wrong. They're going to be potentially harmful. I just had a telemedicine visit with a patient today who was given a diagnosis of myasthenia gravis. I believe that diagnosis was wrong. Her main complaint was fatigue, but she was put on Mestinon, which she thought helped for a week or two, but then it stopped helping, so she's been put on prednisone. The dose of prednisone has been escalated, and without a correct diagnosis, I fear that this patient will suffer all kinds of complications related to incorrect diagnosis. Well, we're not going to be talking about myasthenia gravis, but I think similar kind of problems exist with MS, and it's very, very common. Now, how do we make a diagnosis of MS? Basically, although there have been many, many criteria dating back to Schumacher and then Poser criteria, now we have several iterations of the most contemporary criteria that have been named after the late Professor Ian MacDonald, known as the MacDonald criteria. Basically, all of these diagnostic criteria share two characteristics: that there are lesions in the central nervous system disseminated in time and space, and the second is that they are due to idiopathic inflammatory demyelinating disease of the central nervous system. And because we don't have a way of demonstrating that, often it's termed in the diagnostic criteria that there are no better explanation. As you read most iterations of the diagnostic criteria, clearly the aspect of dissemination in time and space dominates the manuscripts that describe these diagnostic criteria. And here are the diagnostic criteria, a summary at least, from the 2010 criteria. We'll talk about some revisions that have been made in 2017, which are very minor. But basically, there are three categories: clinical attacks, lesions that are demonstrable on neurologic examination, and additional criteria, almost all of which relate to MRI findings, with the single exception in patients who have progressive MS, who are progressive from onset, where CSF actually does count. This was as of 2010. Now, there are some important things I'll point out. There are patients who are completely asymptomatic, who have MRI findings very highly typical of MS. These have been studied in increasing detail, and these patients have been followed. They're called patients with radiologically isolated syndrome, basically asymptomatic, but MRI findings for MS. But as of today, we cannot make a diagnosis of MS in that group of patients. Furthermore, there must be at least one clinical sign. In a patient with a normal neurologic examination, one cannot reliably make a diagnosis of MS. But much of the diagnosis of MS right now relies on MRI criteria to establish dissemination in space. But the criteria, as of 2010, have been greatly liberalized to the point that all one needs to show is 2 T2 hyperintensities that are present in 2 out of 4 areas of the central nervous system: periventricular, juxtacortical, which means a lesion in the or touching the cortex, infratentorial, so a lesion in the cerebellum or brainstem, and spinal cord. But if you have just 2 lesions, that satisfies dissemination in space. Now, there was a caveat in 2010 that I will tell you in 2017 has been removed, that if one had a symptomatic lesion, that one would not count in the dissemination in space. So if there was a symptomatic lesion that was gadolinium enhancing, you would need 2 other lesions. This has now been further liberalized as of 2017, and there is no distinction between a symptomatic and an asymptomatic lesion. To demonstrate dissemination in time, there was a big change in 2010, because until then, there would have to have been a clinical dissemination. We would have had to wait until the patient had either a new symptom and or sign, or in follow-up, a new MRI lesion was detected. But as of 2010, if there was a combination of a gadolinium enhancing, presumably acute lesion, and a non-gadolinium enhancing lesion, presumably an old lesion, this would now satisfy lesion dissemination in time. So as you can imagine, many patients who would have been labeled clinically isolated syndrome, a first episode suspicious of MS, but not having definite MS, as of 2010, with this liberalization, suddenly those patients became not clinically isolated syndrome, but in fact patients with definite MS. Positive spinal fluid, which we all recognize as being an important finding in the spinal fluid that can improve the rigor of our diagnosis, was only contributory in patients with progressive MS. Otherwise, because of the liberalization, positive changes in the detection of oligoclonal bands or elevated IgG index did not contribute to the diagnosis. Charles Poser, who was the author of a previous iteration of diagnostic criteria, wrote about these criteria and said, you know, we're moving toward techno-diagnosis. And he said this in a somewhat disparaging way. And there was a lot of pushback by members of the McDonald Committee, and they said, no, you could establish a diagnosis purely on clinical grounds. But I think Poser did envision what was going to come, and that is that diagnosis was going to be heavily dependent on neuroimaging, and in a few minutes, we'll talk about what the consequences of that have been. Well, just to be complete about diagnostic criteria, there were some minor revisions in 2017, the biggest of which was reintroduction of oligoclonal bands into the diagnosis, not to really take full advantage, in my opinion, of what the value of oligoclonal bands is, because I think the real diagnostic value is if they are absent, then this should be a red flag. But that's not how oligoclonal bands were reintroduced. They were reintroduced to further liberalize the diagnostic criteria and say that if you had oligoclonal bands, you no longer need to demonstrate dissemination in time. The presence of oligoclonal bands alone would replace the requirement for dissemination in time. I talked about the difference between symptomatic and asymptomatic MRI lesions, and this distinction was removed in determining dissemination in space. And a further minor clarification was that if you had a purely cortical lesion, that was treated the same as a juxtacortical lesion. So those were the main changes in the 2017 criteria. Okay, well, we've been talking about counting dissemination in space, dissemination in time, but really, in my opinion, when I'm seeing a patient and trying to determine if they have MS, the critical criteria for me is, do they have an idiopathic inflammatory demyelinating disease of the central nervous system, which is really the tough thing to demonstrate. And the result of these criteria and the liberalization and requiring very few lesions, and in general, this push to early diagnosis has resulted in a major problem with misdiagnosis. Now, when we talk about misdiagnosis, there can be various levels of it. The first level is MS is suspected in the differential diagnosis, you're not sure, and you request a second opinion, which is perfectly legitimate and not a problem at all. The next level would be giving the patient a tentative MS diagnosis, but recommending observation. Often what's told patients is, well, I can't really prove it's MS, but I can't think of what else you might have. In most patients' minds, that is telling them that they have MS. The next level would be starting patients on a disease-modifying treatment. And as I will tell you, it is amazing how many patients with a possible diagnosis of MS, but not very well substantiated, are initiated on MS long-term disease-modifying treatments that in the United States would cost $80,000 a year or more. A higher level would be, well, we need patients for clinical trials, and you might have MS, we'll put you into a clinical trial. And as I'll tell you, there are quite a number of patients with ultimately disproven diagnosis of MS, they did not have MS at all, who were participants in MS clinical trials that are used to tell us how we should be treating MS patients. Many patients who have symptoms and are treated with MS disease-modifying treatments and get no benefit because they don't have MS, come back with more symptoms, and doctors who have given them a diagnosis of MS will escalate treatments, often to more risky treatments. And It's only after several courses of disease-modifying treatments that it's recognized that they didn't have MS. How common is this? There are various estimates that go anywhere from 13%, this was in a series in Nova Scotia, Canada, up to 67%. I like this more recent series, which was from UCLA and Cedars-Sinai. It's very recent, published in 2019. And the estimate is 17 to 19% of patients at these two large hospitals in Los Angeles who had established diagnoses of MS. Almost all were on disease-modifying treatments. They're seen at a tertiary referral center, and it's decided that they did not have a correct diagnosis of MS. And this may be a bigger problem in Western countries and in the United States than other countries. Patients who pay for their healthcare out of their pocket, often there's more pressure on doctors to come up with an early diagnosis and initiate treatment. But I would point out that there was recently a study from Beirut and Kuwait, published again about a year ago, that found roughly the same proportion of patients who it was judged after thorough review at a tertiary medical center that the diagnosis was incorrect. Dr. Andy Solomon at the University of Vermont, in a collaborative study, actually at Mayo Clinic, we were the major contributors to this study, looked at 110 misdiagnosed patients. As I mentioned, we contributed 55% of the patients at Mayo Clinic. And in fact, the misdiagnosis was usually not or was often not from a physician who had very little training in MS. A quarter of these misdiagnoses were patients with MS fellowship training or a practice focus in MS. So this is not just a problem of non-subspecialty neurologists, but it is a general problem. And 4% of the patients who were misdiagnosed had been participants in a clinical therapeutic trial. Now, what was the correct diagnosis? And there is a long list, and there are many rare diagnoses that were missed, but 2/3 of these patients did not have brain tumors or genetic leukodystrophies or any other exotic diagnoses, but the usual diagnoses that led to a misdiagnosis was migraine, fibromyalgia, non-specific or non-localizing neurological symptoms with abnormal MRI, conversion disorder or psychogenic disorder, and really the only major important diagnostic conundrum was neuromyelitis optica spectrum disorder, which accounted for 6% of the misdiagnoses. But the vast majority of them were these conditions for which definitive tests don't exist. They are clinical diagnoses. How long was the duration of misdiagnosis? In 1/3 of patients, longer than 10 years. As I mentioned, 70% of patients had received disease-modifying treatment. 36% received more than one. And a sizable percentage of patients, 12%, had received 3 or more disease-modifying treatments until ultimately it was figured out that the diagnosis was wrong. As I see it, the main reasons for misdiagnosis are nonspecific symptoms and nonspecific radiologic findings. Alone, I think we all recognize that there are patients who have nonspecific white matter lesions. We all recognize nonspecific symptoms, but when patients have both, they seem to acquire added significance, and it's impossible to rule out MS, and have some tingling and numbness in this arm and leg and fatigue, and oh, there's 10 white spots, maybe 1 or 2 are periventricular, and the pressure to make a diagnosis, and the patient is given a diagnosis of MS. And I don't know how many of you have gone through this experience. This is an experience that I go through almost every month. It is never a happy experience for either you or the patient. You may think you're giving them good news. You don't have MS. Isn't that wonderful news? But the patient has been out of a job. They may have had fibromyalgia, but now you're telling, but they thought they had MS, and you're telling them now you don't have MS. Maybe they're going to lose their disability benefits that they've been receiving that have been the source of their income. It's really a disastrous thing that is never a happy situation. And the important thing is that we do this as rarely as at all possible. How does MS present, and what is the differential diagnosis? It can present in different ways, either multifocal, relapsing, remitting lesions. It can be considered when there's a single lesion. In fact, we've described a number of patients with progressive myelopathy who have a single lesion, typically at the cervicomedullary junction. Often they're thought to have an indolent glioma, and they have oligoclonal bands. We call this solitary sclerosis. Patients who have other kinds of progressive myelopathies, other progressive syndromes like optic neuropathy and cerebellar ataxia, patients who have diffuse white matter lesions, leukoencephalopathies. Some of them are genetic leukodystrophies, and we're learning of more and more that present in adults. And it's, of course, often suspected in patients who have MRI lesions with nonspecific symptoms, those patients with fibromyalgia, migraine. So I have differential diagnoses, and looking through lists is kind of a boring thing. So I'll go through just a couple of these, but typical things that we would think of in patients who have multifocal, asynchronous, relapsing, remitting symptoms are patients with stroke, especially vasculitis, antiphospholipid antibody syndrome, metabolic strokes like mitochondrial disorders, Susac syndrome, a vasculopathy. These are ones that are all potential MS mimics. To go through the differential diagnosis and how we distinguish each from MS would be a long discussion in its own right. Lymphoma sometimes can have a multiphasic course. We have seen patients who have presented with MS-like syndromes, even had brain biopsies that have shown CNS demyelination, and then represent with another lesion that on biopsy is shown to be lymphoma, a rare occurrence, but can occur. Klippers is a syndrome recently recognized of multifocal brainstem lesions with a particularly characteristic kind of enhancement pattern in the brainstem. Sarcoidosis, histiocytosis. Certainly solitary lesions, I've talked about how some lesions may be demyelinating, but we think of tumor and abscess. Progressive myelopathy can be either compressive. Sometimes it's very obvious what the cause of the compression is, but sometimes it may be quite difficult. And in fact, spondylosis tends to cause intramedullary T2 hyperintensity, which may be confused with myelitis. And we've described a very characteristic kind of gadolinium enhancement pattern that looks like a flat transverse band, or we've called it a flat pancake. And when you see this, this is a very good indication that the lesion is compressive. And there are non-structural causes as well: genetic, infection, infiltrative, paraneoplastic. I'm going to just move on. Leukodystrophies. Of course, there are many causes for leukodystrophy that are not genetic, HIV and PML to mention some. Laminin B1 mutations, I've recently seen a patient with that. It's a kind of leukoencephalopathy with cognitive impairment, with prominent autonomic dysfunction, as this patient had. This CSFR1 mutations have actually been kind of mutation recognized at the Mayo Clinic, associated with a particular pathology with axonal spheroids. And we recognize these because on MRI, there's very persistently diffusion positive weighted lesions on the diffusion weighted sequences, and we see these lesions persistently diffusion positive, can help us recognize these leukoencephalopathies with axonal spheroids, often associated with colony stimulating factor receptor 1 mutations. Okay, I think I'll just move on from here to the next part of the talk. So basically what I've done so far is describe to you the problem, the frequent problem of misdiagnoses, the fact that diagnostic criteria are very liberal, and the important thing for us is to be sure that the patient has demyelinating disease. So what is the clinician's toolbox? How do you accomplish this goal? And I don't have perfect answers, but I will describe to you what I think should be in the clinician's toolbox. And the first one is rigor. Next one is looking for specific signs. Wouldn't it be nice if we had a clinical sign that was specific, or radiologic indicators of MS that were specific, instead of just counting non-specific T2 lesions? Red flags are going to be very important for us to help us recognize alternative etiologies. Looking for patterns is very important in making diagnosis. What I described to you in those diagnostic criteria are just counting lesions, counting signs, but we don't just do counting. How did we recognize neuromyelitis optica? Well, optic neuritis, myelitis, those are both indicators of MS, but we recognized, as I'll tell you, certain patterns that told us that, no, this isn't typical MS. This is a unique form of demyelinating inflammatory disease that's different than MS. So it's recognizing certain patterns, and I'll try to illustrate that to you. And finally, and we rarely do brain biopsy on patients, but occasionally getting brain biopsies on patients with fulminant disease that we're not sure is typical prototypic MS can be very, very helpful. And I'll show you one example, perhaps talk of another one. And this allows us to make accurate and early diagnosis, understand the heterogeneity of inflammatory demyelinating disease, and even recognize new diseases that mimic MS. Like, say, for example, Clippers, and like GFAP encephalomyelitis that was confused with multiple sclerosis that was described at our institution. It was really using this toolbox, including pathology, that allowed us to recognize these new diseases. So let's start with each one of these. Rigor. Looking at clinical signs. And again, it's not just counting, it's recognizing which signs are typical, which ones are compatible, and which ones should raise red flags. So with eye movements, internuclear ophthalmoplegia is of course very typical. A sixth nerve palsy is less specific, but quite compatible with MS. But a vertical gaze palsy is almost unheard of, or complete ophthalmoplegia. Now, occasionally there are some pretty bad ophthalmoplegias like 1.5 syndrome that can be seen in patients with MS. So nothing is absolute, but in your mind, you should be saying this is typical, compatible, or atypical and worrisome. Same thing with hemifacial numbness, very, very typical presentation of an attack of MS. Trigeminal neuralgia, most patients with trigeminal neuralgia don't have MS, but in a young person with trigeminal neuralgia, MS is very compatible diagnosis. But progressive numbness of the chin or lip, progressive trigeminal neuropathy, that should be a red flag. We should not be diagnosing MS in those patients. A tumor is a much more likely presentation. Similarly, not all white matter lesions are the same, and a picture is worth 1,000 words. This patient almost certainly has MS, Dawson finger configuration, periventricular lesions. You can see an acute lesion with some surrounding edema. This is very suggestive of MS. Here's a patient with many deep white matter lesions, some of which are periventricular, but I would look at this and say it's very unlikely that this patient has MS. This is much more suggestive of ischemic degenerative white matter changes that are associated with aging. A very helpful review discussing the interpretation of findings on MRI scans was published last year in Brain by Massimo Filippi and colleagues. I was very honored to be part of this group. I think it is a very helpful paper, and so things are improving. Red flags, when they're present, are very critical, and a single red flag can often make the diagnosis. And you can put them into several categories: demographic characteristics, patient with cancer. You want to be very careful before assigning a diagnosis of MS. Could they have a paraneoplastic disorder, or could this be a manifestation of spread to the brain of cancer? Is there a specific symptom? Deafness. Transient deafness in one ear certainly can occur in MS, but bilateral severe persistent deafness, I'd be thinking of Susak syndrome among a few other diagnoses. Progressive ataxia as a pure manifestation can be due to MS, but I'd be thinking of a number of other things, spinocerebellar ataxia amongst them. Fragile X syndrome can produce progressive ataxia with middle cerebellar peduncle lesions. A systemic syndrome, if the patient has arthritis, fever, weight loss and malabsorption, many other entities in the differential diagnosis. Sometimes it can be a radiographic finding or a laboratory value. For example, patient with chronic myelopathy who has very low copper levels. We now recognize that that is part of the differential diagnosis for progressive myelopathy, even though I would agree that primary progressive MS would be a much more likely possibility, but low copper is treatable. Our treatments are much less good for primary progressive MS. I talked about patterns. Before we used to count, but for example, with epilepsy, we've recognized that just counting seizures would not tell us what diagnoses are. We recognize epileptic syndromes that tell us a bit about the etiology and the response to treatment. In the same way, we've learned to put together demographic characteristics, severity of clinical manifestations, MRI findings, and even biomarkers like NMO-IgG to distinguish neuromyelitis optica from MS. And I'm sure this is all familiar to most of you now, seeing these kind of chiasm lesions with prominent swollen chiasm, longitudinally extensive myelitis, and the brain tends to be spared. And this is a historic slide, but the way we used to detect aquaporin 4 antibodies by indirect immunofluorescence on mouse tissue, and we would see this peel and perivascular pattern of staining. This is how we recognize neuromyelitis optica as a distinct disease. And it's important because it responds differently to treatments. Now let's talk about specific findings. And as I said, wouldn't it be nice if we had a specific clinical sign for multiple sclerosis? And I'm going to talk about McArdle's sign, which I suspect not many in the audience would know anything about. What is McArdle's sign? Really, this is based on something that was taught by M.J. McArdle, who most of you have heard of Brian McArdle of McArdle's disease and phosphorylase deficiency. This is his brother, who was much less prolific in publication, but was known to be an excellent clinician. It was at Queen Square Hospital. And he never published this himself, but some of his students in 1987 published a single case of a patient, and I'll show you a video of a patient pretty much the same as was described in that paper, who could only walk if he tipped his head back. And if he tried to go downstairs, go down the stairs and he put his chin down, he couldn't walk, couldn't move his legs. And I'll show you a video that I think is fairly typical. Let me just bring up that video now. Hopefully this will work. I've been coached on how to do this properly. So optimize screen sharing. And hopefully you can see this. And I'll play
This patient with chronically progressive multiple sclerosis has a spastic paraplegia worse on the left. We recently observed that his walking ability changed markedly with the position of his neck. We'll first observe him walk in the normal manner. He's walking with his neck extended, which he finds assists his walking. You'll see that he has a spastic diplegia worse on the left. He needs the aid of a walker in order to walk. We'll now ask him to walk first with his neck extended and then to flex his neck with his chin touching his chest. Observe the difference in his gait. Here he begins to walk with his neck extended, and we'll ask him to touch his chin down to his chest. He's immediately frozen, and we are asking him to walk now, and he's unable to. He's unable to move his left leg at all. We ask him to extend his neck, and he resumes his normal gait.
Okay, so I'm going to, can you all see me now?
Yes.
Sudhir, can you see me?
Yes.
Okay, so before I get back to my slides, I'm just going to tell you the follow-up to that. That was a patient who I'd seen in the 1980s, and this was thought to be a rare manifestation. There was only the single case report, but I wondered whether this might be a more common phenomena in a much less dramatic way that might be detected in many MS patients. So over the course of many years, I studied the strength in a number of different muscle groups. I would examine the patient with their neck extended and then their neck flexed. And what I found is the most helpful muscle group was finger extensors. So I'd ask the patient to extend their neck, try to overcome their finger extensors, which is, I would say, nearly impossible in most normal individuals. And then I would ask them to flex their neck, and many, if not most patients with multiple sclerosis, even patients who have no or minimal baseline weakness in their finger extensors, when they flex their neck, they become significantly weaker in terms of their finger extensors. This I found to be the most helpful muscle group. Well, I'm going to go back to my slides now. A couple of years ago, I decided to get serious about this. I'd been studying this and I'd been showing this to residents, but I figured no one would believe me if I tried to publish this. I'm trying to advance. Okay, so we built a device. And basically it consists of a torque cell, and the patient's hand goes in here and their fingers are up against the bar, and we have a lever here, and we start out with the patient's fingers extended, and we ask them to extend their neck, and I'll show you the outputs that we get, and then we push against their fingers. This was the isoinertial paradigm, which was the most sensitive to detect this sign, closest to our clinical exam, and this is the output that we got using a program called LabVIEW. And the blue represents the peak strength, and you can see our healthy controls. And what I show here are 5 trials of serial extension, flexion, extension, flexion, extension, flexion, so forth. You can see very little change. Here's a patient with another kind of myelopathy, essentially no change. But look at this patient with MS. Extension, flexion, extension, flexion. Now this is a dramatic example, and I'll show you what the mean data were in our study, but you can see a very consistent and dramatic drop in peak strength. The orange represents neck position, because we had this device that recorded neck position. You can see down is extension, and when we ask the patient here, their neck is flexed, so this orange has gone up. Here's our blinded study. We studied 106 patients with either MS, other myelopathies, a peripheral nerve lesion like a C7 radiculopathy. Some of them had other lesions associated with finger extension weakness, and here's healthy controls. MS patients, we did not enroll them because they had McArdle sign. All that we required is that there was some degree of demonstrable finger extension weakness at baseline. In fact, when we looked at the average strength, actually the MS patients were stronger than the other groups. So the differences I'm going to show you are not because the MS patients were weaker. But if we look at the proportion drop in the peak torque between extension and flexion, it was 17% in the MS patients, essentially 0 in the controls. Here it's shown diagrammatic or in a figure. You can see there's virtually no overlap between the healthy controls, patients with peripheral nerve lesions or other myelopathies, but a median of 17% decrease in strength with flexion. And when we looked at the correlation with the clinical sign, and we rated each patient as 1+, yes, I believe there is McArdle sign, 2 is yes and fairly prominent, 3 is very prominent. There was a reasonable correlation between the clinical rating and the measurement with this device. And when we looked at the diagnostic properties in terms of area under the curve analysis, you can see that using this isoinertial paradigm, at 10% reduction, at a cutoff of 10% reduction in strength between extension and flexion, it was 100% specific and 62% sensitive. 62% of the MS patients had this sign, and it completely discriminated MS versus other myelopathy. And similar, looking at MS versus healthy controls, a 6% reduction was 92% specific and 73% sensitive. So McArdle sign, I'd argue, is really one of our only specific signs of multiple sclerosis. We believe it is due to stretch-induced conduction block, but we are in the process of doing electrophysiologic tests to further confirm this. It's easy to demonstrate, rapid, inexpensive, and a generally reliable bedside test, highly specific and moderately sensitive for a diagnosis of MS, and we think demyelination, and may facilitate the diagnosis of MS in certain clinical situations. For example, we had one patient who had a solitary cervical spinal cord lesion, no brain lesions, oligoclonal bands, and the McArdle sign was easily demonstrated in this patient. What about specific radiologic tests? You may have heard of the central vein sign, which is shown here on the left, detecting the presence of a flow void indicating a blood vessel. And this can be studied in multiple planes. And when you can see a blood vessel consistently or in a fairly high percentage of lesions coursing through the lesion, this seems to be a good indicator that we're dealing with MS and not other non-specific white matter lesions. And in fact, several other pathologies have been studied where this central vein sign is not present. There are some difficulties. Another specific radiologic finding was described by my colleague, Dr. Jan Mendel-Telema, whose picture is shown there. And he developed a sequence with our radiology colleagues called gray matter double inversion recovery, GMDIR. And you can see on these lesions demonstrated on T2 that with GMDIR, you see a fairly prominent rim around the lesion, dark rim. And on non-specific white matter lesions, you do not see this. In fact, in his study, these rims were found in 35% of MS lesions compared to 1% of patients with non-specific white matter lesion controls. when he looked by subject, 97% of MS patients had more than one rim lesion, compared to only 22% of the controls. But it was associated with lesion size and T1 value. When comparing this against the McDonald 2010 dissemination in space criteria, it substantially increased the specificity. You can see one rim alone, the specificity went up from 17% to 83% in terms of diagnosis, and 3+ rims was up to 100%. They believe that this represents an artifact of the inversion recovery sequences that they call the bounce point artifact. The exact relationship to the pathophysiology is not too clear, and I'll refer you to his paper for a more detailed discussion. Other specific markers are things like aquaporin 4 IgG. We think MOG IgG is a specific marker. A condition that rarely looks like MS, but sometimes can be confused, is GFAP IgG. The first and the third were markers discovered at Mayo Clinic. There is interest in metabolomic and miRNA profiles, but it seems like these are not specific. They increase the likelihood, and this is more of a machine learning, artificial intelligence approach that seems to, in ways that we don't fully understand, identify certain profiles that increase the likelihood that something is MS, but they're not like aquaporin 4 IgG that are diagnostic and related to the pathogenesis directly. Finally, I'll just say one or two words about pathology. We rarely do pathology, but we've learned, and this is a study from Wolfgang Bruck in Germany. It was a patient who had an unusual lesion in the splenium of the corpus callosum, several other brain lesions, had a history of optic neuritis and myelitis. They weren't sure what was going on with these brain lesions. When they did a biopsy and stained for GFAP, unlike the normal white matter, they found the lesional white matter had these truncated astrocyte processes, and when they stained for aquaporin 4 in their sample, there was extensive loss of aquaporin 4 in the lesion. And then they tested for NMO-IgG. That's not the correct sequence, but I think it helped show how in some patients with unusual brain lesions, where one is suspicious that they may have different pathology, pathology can be helpful. I have another story about acute disseminated encephalomyelitis and how helpful pathology can be in that situation. I think that's another example. And some patients with very extensive white matter lesions where that's in the differential diagnosis, that can be helpful. So I'm just going to conclude and have some time for questions. The first point is misdiagnosis of MS is very common. The most common misdiagnosis is not things like brain tumors and leukodystrophies. They are common conditions, often without specific diagnostic tests like fibromyalgia and migraine and other nonspecific symptoms with nonspecific white matter lesions. And this can be a somewhat disastrous thing to misdiagnose a patient, and very, very hard to correct. So it's very important for us to keep it in mind. And much as I do support the importance of trying to make a diagnosis early when MS is clearly causing problems, in patients where you're really not sure, which is often in patients where the neurologic exam is fairly normal, it's best to be as sure as one can be. I would say about 85 to 90% certain before starting disease-modifying treatment. Maybe it's MS, 50-50 is not enough to initiate treatment. And we're looking mainly for evidence that this is an inflammatory demyelinating disease. And the tools that I told you about were rigor about interpreting clinical signs, about interpreting MRIs, being aware of red flags, being aware of certain patterns, looking for specific findings, clinical, like McArdle's sign, and we talked about radiologic findings, such as the central vein sign, and certain specific biomarkers that we now have. And finally, how pathology can help us in some difficult circumstances. And I'll just end with a quotation. This was a debate that was recently published in the MS Journal. I was not a participant in that debate, but I do like the intent of things, and I think we need a new approach for the future. And the debate was, instead of tweaking the diagnostic criteria for MS in those with CIS, which is what we've been doing for the last 20 years, we should develop diagnostic criteria that distinguish MS from other conditions. And I invite you to read the pros and cons and the summary of that debate. I think it makes for some interesting reading, but I think it's an important point. And on that note, I'm going to end, and I'd be happy to take any questions.
Right. So I've been actually I was busy typing out questions. So what I'm going to do is share my Sudhir. I'm sharing my PowerPoint.
Okay.
Yeah. So here it comes on. There. Okay. So I'm sorry if anybody has questions after say more than about 15 seconds ago. We'll have to let them pass. But these are the questions that we do have now, and that I'm going to be reading out. So this is from the first from Dr. Singhal. In patients on rituximab not immunized at the start, when can they be given varicella zoster vaccine? Now, Dr. Singhal, as usual, began with an apology and said, these are treatment related, should we be doing them? I said, sir, these are important. So we will take them. And Brian, would you be okay with answering them? Otherwise, he's happy to send them by email as well.
Okay. Well, I think the first point is that we try to avoid live vaccines like MMR in patients who are on immunosuppressive medications, including rituximab. In general, we try to think of every vaccine that a patient should have and administer it to them before they start rituximab. I know that's not quite the question, but I think that's an important point. If I did have a patient who was not, who was on rituximab, and say, for example, I wanted to give Shingrix, the new vaccine, I think it would be most likely to be effective if I gave it before their next dose of rituximab. So that's probably when I'd administer it to them, not shortly after they've received rituximab. So I hope that answers the first question. During COVID-19, what about teriflunomide? Yes, this is a big issue, what we do with MS patients. And there are several useful documents and websites that I'm happy to share that provide some general guidelines. Now, often the evidence is not very good, but say, for example, interferon and glatiramer acetate are believed to be generally safe. Medications like alemtuzumab and cladribine probably are pretty risky, T-cell depleting medications. We also regard medications like ocrelizumab and rituximab as somewhat risky. Most of us are advising that if the patient had fairly active MS, or that we probably don't want to defer giving them treatment. But if I had a patient, say, for example, with primary progressive MS, where I believe that the benefits are very modest, in fact, I often don't recommend it in patients with primary progressive MS, but In the United States, at least, many patients with primary progressive MS, based on the Oratorio study, are on treatment, but I think the benefits are pretty weak. I'd probably hold off giving them their reinfusion until the COVID situation was somewhat better. Teriflunomide is generally regarded as a low-risk medication and one that can be continued, but I think we don't exactly know.
What about
So-
dimethyl fumarate?
I don't think I would.
Dimethyl fumarate also you will hold on?
You know, I think that's considered an intermediate risk. I think it's one of those things that would have to be individualized. If I had a patient who was fairly stable for quite a long period of time, I might hold on it, possibly even reduce the dose, although we don't have a lot of data. Usually we really emphasize to patients on these medications the importance of social isolation, hygiene. That's often the big recommendation. But we don't want the patients to have attacks which are going to bring them to the hospital and put them at even greater risk. So that's probably counterproductive, withdrawing treatments. And
Okay.
if after first dose of rituximab, when next dose is due, if CD19, 20 are 0, can we withhold next dose? With COVID, I assume.
Even otherwise, even otherwise.
Well, you know, I would say that I always take the peripheral B cell counts with a bit of a grain of salt, because B cells reconstitute probably in tissues before they are reflected in the blood.
Okay.
And when they do start coming back, they often come back very rapidly. You can have a patient who's 1%, the next month they're going to be 10%. And especially with NMO, my bigger experience is with using, I have less experience with this with MS, but with NMO, I think it's a risky time. And that's why we generally recommend every 6 months, even though that's probably before the B cells fully reconstitute, because we want to generally keep those B cells and the antibody very suppressed. And of course, attacks of NMO can be severe.
Fair enough.
Whether this applies to MS is a little difficult to say.
So generally now we have stopped checking the CD19.
We'll go on to the next question, Subir.
Yeah, no, have you stopped doing CD19-20, or you just give regularly every 6 months?
We don't do CD19-20 on a regular basis. The only time I do them is if the patient relapses, because at that point I want to know whether they've relapsed because they've reconstituted early or in spite of it, in spite of no reconstitution. Because that will, I might change the interval of
Hello.
Yeah.
Oops. Brian's just lost.
0 counts. I might be thinking more of switching treatment. So I think it's helpful then, but I think this business about, you know, checking regularly and only redosing, it just risks getting the B cells reconstituting and missing that point where you could have prevented an attack.
Thanks. That was really useful. I mean, that's something that actually is going to impact my practice. So, Brian, we'll move on to the next set of questions.
Okay.
This is these are all random stuff, and then there is a bit of questions on what I'm going to call the McArdle Weinshenker sign. So,
Okay.
are you okay with overstepping your time a bit by about 5?
Yes, that's fine with me, yes.
Okay, so then these are the next questions. If a patient has new enhancing lesions in an MRI, asymmetric pyramidal signs, but no relevant symptoms.
What would be the management? Okay. Well, we do worry about new lesions, especially enhancing lesions, and there are a number of studies that say, in particular in patients who are on treatment, and this dates back to work from Richard Rudick in patients on interferon, detecting gadolinium enhancing treatments in a treated patient does seem to predict worse disability down the line. And yeah, if I saw this, especially more than once, I'd be more concerned about a gadolinium enhancing lesion than a new T2 lesion. I might consider a change in treatment.
Okay.
It's a bit of a controversial area. I don't think we have all the data that we need, and often this has to be individualized, but we are concerned about new lesions, especially gadolinium enhancing lesions.
No, this is relevant because you see, we don't have expertise on EDSS. So, I mean, if somebody is managing an MS patient and is not able to reliably do an EDSS, then you have nothing other than the MRI to look at progression. Especially if your radiologist is not going to be able to do a very detailed study, not done it technically right. So at that point, I'd take that new MRI enhancing lesions, we need to start watching out.
Early MS is mainly a silent disease. And we do see a number of patients in the past who they said they were fine for years, but somehow they've developed progressive disease and now they have a huge lesion burden. And when did all those lesions happen? They usually happen silently, the vast majority of them.
So sorry to interrupt. My own policy is to, in almost all patients, is to get a double dose contrast enhanced MRI at least once a year. In India, it's not that expensive, even if patients are paying out of their own pocket. You think that's reasonable?
I think relapsing remitting patients, yes. I must say we do them at Mayo a little less frequently, about 18 months to 2 years is our general, but I think it should be individualized. If I had a patient who I saw with a lot of gadolinium enhancing lesions or had a number of symptoms, I would do them earlier. I don't think one size fits all, but every year to 2 years, yes. Patients who have late advanced progressive MS, where you haven't seen a new lesion in many years, probably doing a lot of MRIs is not that helpful in that patient. But in the early patients with relapsing remitting MS, yes.
I just
right.
want to.
So the next is
one second, isn't our target NIDA? You want no evidence of disease activity. So if you do see a new enhancing lesion in a patient whom you are treating, you would want to scale up your therapy?
Yes, this is a very controversial area. I mean, I think that became one of our targets of treatment is no evidence of disease activity. Some of the recent work from UCSF, was published in the Annals of Neurology about 2 years ago, suggests that achieving NIDA really may not predict outcome in the long term. And there are a number of people who feel that although gadolinium enhancing lesions and new lesions indicating immunologic activity are important and can cause additional problems, that there is some degree of chronic axonal glial disease that is MS that is separate from the immunologic decoration that occurs on top of it. And whether we probably can't realistically achieve NIDA with any medication that we have now. And if that is our goal, we'll probably be switching treatments every year or 2 years, and maybe from a treatment that's really helping this patient, because, you know, what is realistically an expectation, and that may vary from patient to patient. So I think we try to, as close as possible, keep the immunologic evidence of inflammation suppressed, but not perfectly. And I think we recognize there may be other components to this disease that we don't have treatments for.
okay. So I think the next question, inherited errors of metabolism that can be confused with MS, what approach if it is not fitting a specific leukodystrophy pattern on radiology? Would you like to take that? I thought you did answer that.
Yeah. What errors? Well, we talked about copper deficiency. We talked about, well,
Yes.
maybe I didn't mention B12 deficiency. That certainly can cause progressive myelopathy. Is sometimes or quite often a fairly specific pattern in the dorsal columns. Other metabolic diseases, the genetic leukodystrophies, we're getting to understand better and better. Mitochondrial disorders are also genetic diseases that can mimic multiple sclerosis, not infrequently.
So just taking on
Whole
from there.
G mutations can, yes, sorry.
So when would you kind of switch and ask for a gene panel?
Well, we rarely would ask for a gene panel. I think it's, again, the clinical recognition, combination of the clinical pattern, if there's a progressive course, especially in a younger person, but even in an older person, that always raises concerns because it's less specific than relapses and remissions.
Okay.
So that always makes one look harder. And then it's often MRI patterns that would suggest a leukodystrophy. We're recognizing specific ones. For example, as I mentioned, the CSFR1 mutations. You see this extensive periventricular T2 signal abnormality that's diffusion weighted positive. And you might think, oh, well, could this be ischemia? But you repeat the scan in 6 months, it's still diffusion weighted positive. Okay. And that would make one think of this condition. I mentioned the patient who had a diffuse leukoencephalopathy and had orthostatic hypotension that was quite severe, severe urinary retention, and suspected laminin B1 mutation. So we often do this in a very targeted way, but there are patients where we're just unsure and there's diffuse white matter abnormality. Could it be demyelinating disease or genetic? And we do whole genome sequencing. I have genetics colleagues who help us out, and occasionally we've come up with diagnoses going that approach.
Okay. Then moving on, involvement of more than 2 spinal segments of the spine with characteristics of MS. How do you differentiate from NMO?
Okay, well, the first thing is that it's really, we're talking about an acute myelitis. NMO practically always presents with acute myelitic symptoms, so I'm looking for that. A very common misdiagnosis are patients who have chronic progressive myelopathy and have conglomeration of multiple lesions in the spinal cord over 3 or more segments, but their course is progressive. They have oligoclonal bands. Those patients have MS and not NMO. So a key question is to ask, does this patient have recurrent acute myelitis? And one thing we've learned is that some patients with NMO don't have the 3 or more segments. In fact, 2 different studies, one from South Korea and one from our group, reported about 15% will have shorter than 3 lesion. Now, they're often central within the spinal cord, and many of the patients experience relapses with longer lesions. But if you see those central cord lesions, you should be suspicious of NMO. Of course, there's a broad differential diagnosis for long spinal cord lesions, and there are a number of excellent reviews on, I don't want to say that, for example, sarcoidosis can cause long spinal cord lesions. We wrote a paper in Annals of Neurology a couple of years ago about some very specific gadolinium enhancement patterns the dorsal subpial enhancement or trident sign, which distinguish sarcoid from NMO. So longitudinally extensive spinal cord lesions does not equal NMO. That's a very important point.
Right. So the next one, atypical demyelination, I think you answered that. So we'll drop that. Any tips on not getting tripped up by ischemic demyelination, small vessel disease?
Yeah. Well, I think a key one is there clinical reason to suspect multiple sclerosis? And I showed you those two MRIs. One is MS, one is ischemic degenerative. Now, we'll talk about periventricular. If you've got enough lesions peppered through the white matter, you're going to get a few that are periventricular. So I think just detecting periventricular is not enough. It's the shape of the lesions, the size, the ovoid configuration. All of those things are very helpful. In some patients, it's hard. I think that's where things like the central vein sign may be very helpful as soon as we operationalize this. And several groups have proposed ways to make this more operational and user-friendly, but I think this is something that is almost ready to be integrated into clinical practice, and I think will help us. I think those dark rim lesions that Jan Mendel-Telema reported could be a very helpful thing as well. I think that's really a very nice paper.
Yeah, I need to look that up. So I personally have this thing, and this is something that ends up being an issue with our radiologist, of asking for a FLAIR SAG image. Because if I don't see Dawson's fingers, my antennae stay up until I see them. Is that?
I think it's helpful, but I'd point out, especially in patients with primary progressive MS, many of them have mainly spinal cord lesions and relatively few brain lesions. And I would say I would be reluctant to exclude it, but I do think it is a helpful thing when you see it. But our ability to differentiate MS, if you have the small, tiny Dawson type fingers lesions, they may be hard.
Right. So this is the last on this lot, and then there's one more slide. If a patient has recurrent brainstem syndrome with some non-specific periventricular changes and OCB negative, how would you proceed?
Well, recurrent brainstem syndrome, what would cause this? Antiphospholipid antibodies and recurrent stroke, vasculitis. I think this is where clippers can come in, where there's these peppered lesions through the brainstem, and they often will have not too severe clinical manifestations, but some of them can be relatively severe. And this seems to be a new syndrome that we're able to recognize that is brainstem predominant. I guess we wouldn't forget about listeria, would we, Sudhir?
Yeah.
That would always be in our differential diagnosis.
No, but something that is subacute to chronic, evolving over months, because I have a patient like this, and it's been difficult because he did seem to respond to steroids. We didn't get anything positive. But yeah, I agree. This is, I think this is one of those things.
Look at all like clippers?
What about Behçet's? Even that would come in.
Yes, that's a very good one. We don't see much Behçet's here, but yes, that's certainly one that occurs in the posterior fossa, can cause recurrent lesions, usually quite large in general, larger than typical demyelinating lesions, but certainly something that should be considered.
Right. So we now move on to the myocardial Weinshenker sign, because there are lots of questions on that, and that will be the last of it. So
on this sign, I want to ask this 10% with your with the special equipment you found. How much does it translate into clinical grade?
I think it partly depends on what the baseline strength is. So patients who have some weakness, I think it's easier to perceive the increase in weakness. Some people where they're very strong at baseline or normal, it can be more difficult. So, and I would say that our device, which is really a prototype, is not even entirely sensitive, because there are some patients where I have felt quite confident that they had McArdle's sign on my clinical exam, and we couldn't really demonstrate it, or not to be confident at a confident level and meeting the cutoffs we came up with the receiver operator curve with the device. I would say the device is the most reliable way, of course. Certainly seeing those
I guess
peak
people should,
torques.
sorry, but I guess people should take home the point that this is finally a clinical sign, and the device that you did was essentially to document
Right,
for the
exactly.
paper. I hope people don't start trying to build those.
I think you do need to train yourself to be good at it, but it's not very difficult. And if you start doing this regularly, I'm sure you'll see this in your MS patients. I really have no doubt. In fact, some people have told me, oh, I just can't find this. And then we go over the patient together, and then they agree. But the reason we got the device is because, like I said, sometimes you do this and you think, is this really my imagination that there's somewhat weaker inflection? But sometimes it's just very dramatic. And my experience with patients is they're often shocked. They can tell this themselves, and they look at you when they get weaker with neck flexion, and they sit,
Wow.
they're wondering, what did you do to me? So that I have this. But it goes away as soon as their neck is extended. It's instantaneous. And I see the mechanism. We think it's related to conduction block that's induced by neck flexion. Kind of like Lermite symptom is an electrophysiologic phenomena, but a positive sensory phenomena with neck flexion. This is a negative motor phenomena. But I do think there are some other competing theories about what happens when you extend your neck and maybe activate neck muscle receptors and lead to vestibulospinal and reticulospinal activation. And there may be other explanations that may be a little harder to document that we're trying to pursue, but our leading thought is that this is due to conduction block. An interesting thing is, we did include a number of patients in our study with NMO in the other myelopathy group, and none of them were positive. And I don't detect this in NMO patients, which I find to be really quite interesting, and I think tells us a little bit about differences in pathology between NMO and MS.
Right. So a couple of things more, a little laterally. One was, what about, there always is a worry about atlantoaxial dislocation. And I presume that on the MRI that has been ruled out. But if for somebody were to do it clinically, you think that's something that you would worry about?
Do you mean, would you be afraid to do it in someone with atlantoaxial dislocation? Yeah.
Without ruling it out. I mean, would you want to do it without an MRI?
But you would always have an MRI before. I mean, I don't think the situation will come that you'll do a McArdle sign without an MRI first.
Usually we do have MRIs before we see the patients. It's at least maybe it's the same for you. In the old days, you would not get the MRI until after you evaluate them clinically, but often patients come to us with MRIs done. But if I'm suspicious for MS and they don't have neck pain, I'm not really too concerned about that. In patients with severe cervical spondylosis, and we've tested a number of them, and I've asked them to extend and flex their neck, the extension probably posed the greatest risk. But we do imaging often with patients in extension to try to see if there is some dynamic compression of the cord. So I think this test, which we never push the patient's neck back, we ask them to extend their neck as far as they feel comfortable in doing so.
Okay, that's nice.
Yeah.
So the last one, and that is really the last one. It's a little lateral. Does this tell us anything about the pathophysiology of Hirayama disease? I mean, would you want to answer that, or because that's really lateral?
No, Roop, I think more important questions are how long, I mean, have you
Okay.
checked the
Yeah.
time course? I mean, when you flex the neck, how soon does the power go down? So how long?
Instantaneously.
Okay.
As you saw in the videotape, you could ask patients to do this. Patients who are clinically manifest, which are usually the weaker patients, you can ask them to continue walking, and while they're walking, put their chin down. It's instantaneous, and as soon as they extend their neck, it's gone. There's
And I
no
suppose it
wait.
doesn't happen if you don't have a cervical plaque.
Yeah.
No. I would say virtually all of these patients have cervical plaques, and if they have a relatively small number, let's say a dominant one on the left side, often you'll see McArdle's sign in one finger extensor and not the other. It's usually the side, but many patients have extensive plaques bilaterally, and they have bilateral McArdle's sign, although often it's more apparent on one side. It'll be 1+ on one side, 3+ on the other. But seeing asymmetry is very, very common.
Okay, Brian, I had two more questions. The extensor indicis proprius, the extensor of the finger, is the one which is maximally affected in the pyramidal lesions. So would you want to narrow down and do only extension of the index finger with without neck flexion? That is one. And another question is, do you want to also check the effect on the lower limbs? So the gait, maybe you do a tuck test, see the timing of his gait before and with and without neck flexion.
Yeah. Well, I would say that before we settled on finger extensors, we did in our Mayo Biomechanics lab test a number of different muscle groups that can be evaluated quantitatively. And we did find evidence of this McArdle sign in a number of different muscle groups, but the best was the finger extensors. It was the easiest one to measure, but it isn't certainly not unique to finger extensors. I suppose we're looking for more sensitive ways to detect it. Maybe extensors of the finger index finger might be more sensitive. We haven't really studied that, but thank you for the suggestion.
Right. And so you know what?
And the legs, the gait.
Most patients, it doesn't affect their gait at all. In fact, most patients are completely unaware of this. It has no functional consequence. The only ones where you see a functional consequence are people who have substantial weakness or spastic gait. I think it's just because the threshold is there where this can make a difference. For most people, their strength is so good, has no functional consequence. And I'm just amazed how many patients whose exam is completely normal. They don't have hyperreflexia, no reflex asymmetry, nothing. And the only thing they have on the exam is cardiac sign. Wow. So I think it is a very sensitive measure in patients who have cervical cord lesions, which are 70 to 80% of MS patients when you first see them.
Okay, so I'm going to, I think Sudhir, I am not sure if Brian is a night owl like us.
No, not like
us. This is way past his bedtime. But you know what, Brian? This meeting, this particular session today, leave aside the YouTube, we realize the strength of this after a didactic lecture, the way this converts to a grand round, to something like between a grand round and a tutorial. And it's been incredibly useful. So I would think that the half an hour, I mean, we've been asking you questions for almost about 25 minutes now, no, little more. And that's been as useful as the didactic lecture. And that, I think, for us is probably the way we'll have to evolve this model. And I suppose this is going to go on for a fairly long time.
Yes, he's going to give us some more talks later as his time permits. He has said he's going to talk about it. He has we will have those. Let him, I think we should let him sleep now. Thank you, Brian.
Thanks, Brian.
Okay. Thank you.
Thank you so
Thank you
much.
for inviting me. Keep
Thank you.
well, everybody.
Yes.
Yeah.
Okay.
Bye. Good night.
Bye.